Hi everyone, my name is Med2Med. Today's session is going to be about classifying and treating respiratory failure. These notes are based on the following resources. I've been using Scott's notes and the Oxford Handbook of Clinical Medicine, and as always I've been utilising the NICE guidelines to supplement my work. As a disclaimer, I am a third-year medical student. This video is not intended to be a substitute for any professional medical advice, and you should always consult your doctor about any health concerns. Respiratory failure occurs when gas exchange is inadequate, resulting in hypoxia. That's a PaO2 of 8 kilopascals or less. There are two types of respiratory failure. As we've said, they both are hypoxic at less than 8 kilopascals, but vary on their carbon dioxide levels. So type 1 has normal or even low carbon dioxide, whereas type 2 has raised carbon dioxide of greater than 6 kilopascals. As we've now established, type 1 has normal or low carbon dioxide. This is caused by a ventilation-perfusion mismatch. The VQ ratio is the amount of air that reaches your alveoli divided by the amount of blood flow in your capillaries. A VQ mismatch happens when the part of your lung receives oxygen without blood flow or blood flow without oxygen. There can be hyperventilation, abnormal diffusion, and right to left cardiac shunts. This is an abnormal connection between the right and left sides of the heart, the most common being the tetralogy of Fallot. This is a congenital abnormality. So what causes this VQ mismatch? A pneumonia can cause it, as can a pulmonary edema, pulmonary embolisms, asthma, emphysema, pulmonary fibrosis, and acute respiratory distress syndrome. So we've covered type 1, now let's look at type 2 respiratory failure, where there's hypoxia and hypercapnia that's greater than 6 kilopascals. There is alveolar hypoventilation with or without a ventilation-perfusion mismatch. So what causes type 2 respiratory failure? Well, there's different categories of disease. Firstly, there's pulmonary disease such as asthma, COPD, pneumonia and end-stage pulmonary fibrosis. There's also reduced respiratory drive such as sedative drugs or a CNS tumour or trauma. Then there's neuromuscular disease, such as a cervical cord lesion, diaphragmatic paralysis, poliomyelitis, myasthenia gravis, and GBS. Lastly, there's thoracic wall disease, so that includes flail chest and kyphoscoliosis. Let's explore the clinical features of respiratory failure. Firstly, the symptoms can be split into hypoxia and hypercapnia. Obviously, hypercapnia symptoms will only apply to type 2 respiratory failure, but hypoxia to both. Symptoms of hypoxia include dyspnea, restlessness, agitation, confusion, and central cyanosis. There are also long-standing symptoms of hypoxia, so that's oxygen deprivation over a longer period of time. There might be polycythemia due to an increased erythropoietin production in the kidneys. There can be pulmonary hypertension due to vascular remodeling, and cor pulmonale due to this increased vascular resistance. Quickly moving on to hypercapnia, your patients may complain of headaches, peripheral vasodilation, tachycardia, bounding pulse, a hypercapnic flap, papilledema, confusion, drowsiness, and in severe cases, even coma. The idea of doing investigations is primarily to find out what caused the respiratory failure. You need to do blood tests, such as a full blood count, Usinase, CRP level, and an ABG, which is so important to look for acidosis or alkalosis via the pH. Then there's chest x-rays. You do sputum and cultures if the patient is febrile. And lastly, spirometry, which is really good at looking for those long-term diseases that typically cause respiratory failure, like COPD, neuromuscular disease, and GBS. Treatment of type 1 respiratory failure involves identifying and treating the underlying cause. You give oxygen via a face mask at 24 to 60% saturation and assisted ventilation if oxygen levels fail to rise. And then with type 2 management, again, you want to address the underlying cause. You give some controlled oxygen therapy. Now this is really important because you don't want to over-oxygenate the patient, as the respiratory drive may only be driven by hypoxia and not the hypercapnia. You should recheck the ABG after 20 minutes and consider assisted ventilation if the patient is still hypoxic. Lastly, the last measure would be to intubate and ventilate the patient if all else fails. That's a really quick look at respiratory failure, so let's just recap. There are two types of respiratory failure. We know that both have hypoxia, but only type 2 respiratory failure has hypercapnia, which is greater than 6 kilopascals. VQ mismatches can occur in both type 1 and type 2 respiratory failure, but alveolar hyperventilation only occurs in type 2 respiratory failure. In type 2, the respiratory centre may be driven by hypoxia, as it is not sensitive to carbon dioxide. Obviously, type 1 will only present with symptoms of hypoxia, so that's things like confusion, central cyanosis, and then the longer standing symptoms like polycythemia. But type 2 has mixed symptoms of hypoxia and hypercapnia, so that's things like headache, tachycardia, etc. When we do investigations, we're actually looking at the underlying cause to treat. And lastly, oxygen is a drug, and we should be especially careful when giving it in type 2 respiratory failure, so as not to diminish the respiratory drive any further. Thank you for listening.